So I'd like to invite all of the speakers up to the panel. We have about 20 minutes, and we'll try and stick to the time so that we can have the wrap-up done with sufficient time for a full discussion. As I think about all of the discussion, all of the presentations here, and I think about the previous presentations, the world of data and huge data sets or smaller data sets or merging data together is both intriguing and exciting. I think we all understand that we have to know what's going on before we can even begin to think about how to address it. At the same time, I think about being completely overwhelmed by every different thing we could possibly ask, how to make sense of the data, and more the discussions in large data sets is how to separate the signal from the noise, how to begin to understand and prioritize what we ask, how we ask it, and integrate it, whether it's a registry or an observational study, small single institution studies, or large clinical trials. How do we begin to think about bringing the data together? Because often the data is collected for very specific purposes, and then when you try to merge data sets, it becomes that much more complicated. One of the questions for Kira and Bryce would be, I'm a community oncologist, and how do I begin to even handle asking all of these questions and beginning to deal with it? And then I'll ask those two questions, and then we'll get to the questions from the audience. Bryce?
So thank you, Laura, for that particular question. So, and I do realize that in presenting my one slide of 63 type of perhaps toxicities a child with cancer can experience, I never imagined no one would administer every single question that relates to that. That would actually translate to like 120 or 200 questions. So ideally, I think in the most ideal type of setting that you would only ask about a specific subset of questions. And those would be specifically the ones that you would expect to be targeted based on the type of intervention or the type of cancer the child or adolescent is experiencing. So that would drive some of the symptoms you would assess. In addition, as I noted in that slide, there were some particular 16 core symptoms that are in common from our research that we see are experienced by children regardless of type of cancer, like fatigue and pain and depression and anxiety, and those might populate some of the ways you collect the data. So, however, we have to be careful of information overload and burdening the particular child and adolescent. And so what I see as a system to reduce response burden is, again, using the PRO-CTCAE as a model there, is that system is a screening measure. Where, again, it will quickly ask, are you experiencing pain? No. Okay, let's go on to the next thing. Are you experiencing fatigue? Oh, you are? Let's ask a few more questions that allows us to get a more comprehensive assessment of what they're going on. And what I see this dynamic system as doing is, again, screening which symptoms or functional impact the child experiencing, and then for anything they are experiencing, go a little bit more in depth. That would give us the reliability and sensitivity we need to assess that child at that time and to see for changing that child's symptoms and improving symptoms over time or improving functional impact over time as well. So I think there are ways using what we call adaptive testing or smart logic testing that we can reduce the burden in the cancer care setting.
Thank you for that question. I think it's a very fair one. I think the idea of addressing social determinants in the clinical setting can certainly be overwhelming, and that we worry that we don't know the right questions to ask or how to address them once we get answers. Some of those data that I was showing before, focusing specifically on measures of material hardship, I think an advantage of those to clinicians is that you can screen for material hardship with fewer than 10 questions in a way that takes fewer than 2 minutes, and that's something that can probably be administered in most clinical settings. In terms of what you then do with them, of linking families to resources, I think we've talked a lot here today about the fact that psychosocial supports certainly vary across institutions in the United States. That said, I think the vast majority of pediatric cancer centers have at least one social worker. Whether they have a more robust psychosocial resource team certainly does vary, but perhaps screening in a 2-minute or less 10-question way for material hardship that may be correlated with outcomes could be used to risk stratify families and direct them to the limited social work supports that are then available, knowing that if you're able to link a family with existing governmental resources, you can potentially improve child outcomes.
Thank you. Dr. Badia.
Thank you. Dr. York, actually I have a question for Dr. York and then a question for Kira. Can I have both of those? So first, Dr. York, this is fantastic. It was much needed. It needs to be done. We can't be doing proton beam therapy without having measures that will measure the late effects, given that we have equal outcomes. Now, some late effects occur relatively early, as you know, and some late effects are very, very late, and they occur decades after the treatment is given. So the question for you is, what mechanisms do you have in place to ensure complete follow-up of your cohort, given that this is such a mobile population? We have encountered very, very large attrition rates and loss to follow-up in our patient population.
I think that's a fantastic question, and it's one that we are just starting to consider how to solve. Right now, we are collecting emails from the parents, and if we can, from the patient, if they have one. When they turn 18, we will have to reconsent them, and that will provide us an opportunity to get the direct electronic communication form for the patient themselves. And our hope is to use the REDCap function to not only send out the PEDS QL, but in my future hope is to send out a really basic but important health questionnaire asking about any new surgeries, any new health issue diagnoses, a current med list, that sort of thing. That's going to be the next step beyond the PEDS QL once we prove we're actually successful doing it.
Right, let's talk.
Yeah.
Kira, I'm absolutely enamored by what you're doing. I think the next, or the big question, and I'm sure you're answering those, is knowing exactly what components of the outcomes are impacted most by the poverty measures that you're measuring. And it'll be very fascinating to see if it's delayed diagnosis in any of those. There are some of us out here who don't believe that there is any delay in diagnosis because of poverty. I'd be interested in knowing the answer to that. Or is it other aspects which cause poor outcomes? So.
I think that's a fantastic question and point to which I absolutely do not have the answers. But next steps, I hope we will be able to answer some of that. Whether it's going to be delayed diagnosis, I'm with you. I actually don't think that's likely going to be a driver. But potentially other mechanisms that could be linking poverty to outcomes, whether it's adherence to oral chemotherapy, and whether you take a psychosocial stress model of families who are experiencing material hardship being more stressed than other families and not able to focus on medication administration, whether you take a more biologic model in terms of how children are responding biologically to their chemotherapy. I think there's lots of possibilities there.
Or you look at all of them. And then one of the other pieces to ask would be, are you also collecting communication formats? Is poverty, I mean, there's some things that people, even if they don't have a lot of money, still maintain. And so do these families have cell phones, and does that become an effective means of communication? Because that's the other piece for the follow-up, is finding effective tools to communicate with them even after they've completed their therapy.
My question has to do with the mental health variables that are in a number of these scales and registries, and I think that we need to be very careful, one from a validity standpoint and one from an unintended consequences standpoint. For example, depression, if you have that as an indicator and it's based on one scale or even two scales, parent-child report or something like that, we would never call that depression unless it were truly diagnosed according to the criteria for depression. And so I think we need to be very careful in defining these things and in measuring them, because the unintended consequence, I'm sure we've all thought about this in terms of privacy and impact on the child, and again, do no harm, is that this is going to if this is in the electronic medical record and the child, there's a link to depression on one of these variables, one of these registries or scales or whatever, that's going to be there. They're going to be diagnosed as having depression. It's going to look like that, even though they haven't been formally diagnosed. So I think we need to think about how we look at these mental health variables, because it can have a lasting impact on the child.
So I wholeheartedly agree with that assessment, and I agree we should be very cautious in how we frame and describe when a child self-reports symptoms that are associated with depression. And so I agree, and I apologize if I misrepresented what we're capturing there. And so the goal, as I see, is that we're screening for depressive symptoms, symptoms associated with depression, like sadness and other things like that. But what my goal is that would screen that if something seems to be going on, that would then flag and send an alert to the clinician or make a referral to a psychiatrist that would say, gee, let's talk a little bit about how you're feeling there, and ultimately led to the more formal ways that we diagnose these things before that gets formally put in a medical record. So I agree 100%.
Yeah, I think it would be that when it goes into the medical record. So thank you.
Bob Knoll, Pittsburgh. I shared the similar concern with Mary Jo that in one of the advantages that I see to using, for example, a system like PAT is it isn't linked to psychiatric diagnoses that remain in children's medical records for moving forward. And we were quite careful, as I pointed out yesterday, that when we started our work with caregivers of children with cancer, we didn't say to them, you might be depressed because your child was diagnosed with cancer. We didn't say you might have lots of anxiety. We cautiously avoided that word and simply said, lots of times people are distressed. We have something we want to offer to you. So I just worry that when we use these words of depression and anxiety, that we will have unintended consequences from our screening in terms of what goes on for our kids. I wanted to point out in terms of the radiation work that within the Children's Oncology Group and the Behavioral Science Committee, we have 2 active groups that are looking at the consequences of treatments for kids, one related to Christy Hardy's work, related to using computerized assessments of kids over time, and the second one related to doing direct behavioral examination of kids using a protocol we call ALTE07C1, and it's multiple assessments over time. And it would seem to me linking your registry to what we're doing within the Children's Oncology Group might be a really nice outcome from some of this discussion.
That would be a fabulous way to really bridge what we're doing and to answer some of the comparative effectiveness questions. It would be wonderful.
Carol Hahn, I'm with Duke Radiation Oncology and on the forum representing ASTRO. I want to thank Dr. Yak for her presentation. As Dr. Badia discussed yesterday, we've learned a lot about toxicities of radiotherapy from children and children suffering late effects of our therapy. So very important to learn and to assess where we do have expensive technology, how we appropriately use it. And I'd ask Dr. Yak to comment on some of the retrospective data existing in terms of the potential advantages.
So there are a number of retrospective studies that have come out and are still coming out, and there's actually one, this is a trailer for one I hope to work on the plane ride home. We have 7-year follow-up data on our first phase 2 medulloblastoma study where we do have detailed data on endocrine, hearing, neuropsych, and even a quality of life component. And so that I hope to write up and submit very shortly. But there has been other data that's come out. But again, it lacks a direct comparison group. We're comparing with what's been published in the literature. And I have to say that in writing up these studies with outcomes as the endpoint, not so much disease control, there are very few contemporary studies that really report the late effects in IMRT populations, for example. The Cancer Center survivor studies are absolutely fantastic, but it's just comparing apples and oranges, so it's just not the perfect comparator because they were treated back in the 80s and sometimes earlier. So it's a challenge, and I think the biggest challenge moving forward is getting appropriate contemporary comparison groups. But we will continue to publish single institution experiences, and actually what this Pediatric Proton Consortium has allowed us to do is we're meeting monthly now with the different organizations, and so we've always been relatively close, but we're getting closer. We can now do retrospective multi-institutional studies, and so right now MD Anderson and Florida have been open the longest, so we're trying to pair with them to look at our medulla population for even greater numbers, and then also ependymoma is a common site that we see. So there's data, it's coming out, but I think this is a great way to collect it prospectively instead of retrospectively, because we know that's fraught with some trouble.
Right. I think it's very important to globally to survivorship for oncology, however, because this is where we learn about the late effects, and we need to collect this data moving forward. So thank you.
Thank you.
Jonathan Hagan from the Children's Cancer Therapy Development Institute. My daughter was diagnosed when she was 27 months old. A lot of the data that's been presented over the last 2 days has dealt with children who are a little bit older, who can understand what they're pushing on an iPad. And so my concern is that there's a segment of the child and pediatric cancer population that's going to fall through the cracks, and it's going to fall back upon the parents and the doctors to make those assessments, which in the case of my daughter wasn't able to fully communicate anxiety or fear. Pain we certainly could observe. And some of the data that I've seen presented indicates that there's a discrepancy between what the parents report, between what the physician interprets. So my concern is that this segment of the population is going to fall below the continuum of what we've discussed. My wife and I were very attuned to what was happening, had the resources, put her in play therapy. Thankfully, she didn't have significant periods of hospitalization, but during one of the periods where she was in for 5 days, we insisted on calling in a consult just to make sure that what we were observing was empirically observed by somebody else. Otherwise, it would have been the nurses and the doctors coming in and out making those observations. So where can we fit this segment of the population in this greater discussion so that they're not being underserved in terms of pain management, in terms of anxiety? Because children of that age do experience anxiety. They do experience fear.
John, thank you so much. I am so glad that you asked that question for at least 2 reasons. One is the importance to make sure that we don't miss the voice of the younger children in our care. The second reason, it gives me a few more minutes to talk more about the project, which I didn't have enough time to talk about when I was presenting it. So I agree 100%. We need to find better ways to capture the younger children's perspectives as they relate to both physical and mental symptoms overall. What we are doing in our Pediatric Pro CTCA project, but also it's occurring in other projects I've heard mentioned, including the Promise as well, is But I'll give you the example from what we're doing in Pediatric Pro CTCA is we're not only capturing what the child's reporting, but we're also looking at what the parents, we have a parent proxy report, and we're also going to collect clinician report. And so we're going to look at that triad. And we're going to look at the association between the child and the parent and the child and the clinician and see what type of symptoms parents and clinicians are better or worse at reporting and understanding what the child's experiencing. I think the more observable type of symptoms, nausea and vomiting and perhaps pain as well as the parents and the proxy, parents and clinicians will be better at more agreement with the child. I worry about more the psychological type of symptoms, anxiety, depression. There'll be more discrepancies, but we're going to learn through this project through the studies that we plan to conduct overall. And so the reason why we're doing that is, again, not just to show evidence that there's a discrepancy, but we also need to understand to what extent when the child can't report, can we rely on what the parent or clinicians are saying about that particular child? And again, we hope to inform that situation. Now, but if you see is our current age range starts at 7. We had to start somewhere for feasibility issues there. I'm hoping since NCI is here, they can think of another FOB grant for us to support, because our goal is to now go below that age range from the 5 to 7-year-old and then to below the 5-year-old. Obviously, with each age increase, there's different developmental and cognitive needs that we need to be aware of. We think for children 5 to 7 that while they may not be able to read our questions, we can find some unique ways that the questionnaire can read to them. If this is electronic, they can wear a headset that can actually read the questions to them and they can answer there, or have an interviewer do that. As we start to move to younger age ranges, we'll also have maybe change the way we ask the questions, maybe use graphical approaches, happy to sad faces and things like that. Those things we're starting to explore. However, there is a certain age range where the child just may not be able to self-report, but will have to rely on the parents' reported data. Again, we're trying to build an evidence base to know when that may be more or less reliable or valid. This is informing a much larger research agenda of ours to make sure we don't miss that very important voice.
Thank you. I think we're out of time, but okay. Rebecca said, by all means, go ahead. Final question.
Chris Fiedner, CHOP, underscore something and make sure I heard it correctly from both Richard and Kira. It would seem that the data you presented shows that a huge risk factor for cure, for survivorship, is actually tied to poverty, SES, public insurance status. Both, Richard, the graphs that you displayed where both the publicly insured, whether you be white or African American, is much lower than the privately insured. And then, Kira, all the data that you summarized about the huge, very well-known effects outside of cancer and then bringing them into cancer. What I want to emphasize that seems to be a huge opportunity to improve outcomes. Are we not willing to say that out loud? I mean, like, it's staring us in the face. If somebody had stood up here yesterday and said, I have a drug that will cut mortality risk by 1/3, we would all be clamoring for it. So I just wanted to sort of say, am I wrong about looking at your data? I know you're probably wanting to be very careful, but that seems to be the implication, that you are looking at a huge impact on mortality, event-free survival, and I think we need to really think of that as a huge theme as to how can we emphasize to figure out effective interventions to really bring that difference back to 0 and improve outcomes.
Yes.
It could be a yes or no answer.
Yeah, no,
Yes.
I would say from the FIS and COG data, I would say a cautious yes, right? So our data is induction mortality, first couple months, but that's not, insurance was not significant in the overall 1031 trial, and race was. Now there are additional analyses we need to do to sort of finish teasing that out. And like Smith, I was very struck by the data that Kira presented, and so there may be, I don't know if there are going to be differences by disease. Compliance is less of an issue for AML because all of the chemotherapy is IV in the patient and IV and in the hospital, generally speaking. And there is some treatment-related mortality that's related to early discharge prior to count recovery, but that's very center-dependent, which is very different than ALL, where you have a 3-year or 2-year period where you were supposed to take your chemotherapy at home in an unobserved fashion, and if you don't, you have a dramatic increase in relapse rates. So, there may be some disease-specific, nuances here, but in general, and I thought this was a great point that Kira made, is that this is more broadly applicable, at least in the AML setting, potentially, than any targeted therapy we have, right? The only targeted therapy we have right now is sorafenib, and that's for 8% of kids, not 25 to 30%.
I would echo what Richard said, and Chris, I agree with you. Yes, I personally think this represents an enormous opportunity for pediatric oncology to decrease our residual mortality. I think it's a huge opportunity for targeting interventions for kids in a way that we don't currently do. I would echo, I think, what the conclusions we can draw from the data we presented are preliminary. These are small studies. They have not been replicated in large consortium studies, and that needs to happen. So I don't want to overstate the results we have. I think these are suggestive. That said, they are suggestive of something that deserves investigation. And if in fact it holds true, I think we could move the needle hugely on our residual 20%
Well, all I'll
mortality.
add is if we're reading the tide of change with more oral agents becoming available, biologically active
Yes.
agents that are long-term, we're going to see perhaps even more issues around this. So while I appreciate your cautious interpretation of your data, and I respect that, I think that this is a huge area for us to think about the forefront of improving outcomes, maybe on the psychosocial and the social poverty care angle.
Yes.
And I think there's clear, data in adult cancers to support that in CML, right? There's very, Hagop Kantarjian, has spoken eloquently about the fact that outcome for CML in Sweden is better than in the United States. And that's related, as best we can tell, directly to, in Sweden, you pay $200 a year for all of your medicines, and that's all you have to pay. And in the US, there are dramatic differences, for co-payments for TKIs, where the baseline cost of Gleevec is $90,000. So I fully agree.
Okay, thank you.